Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and Professor Kermansaravi, well-known bariatric surgeon, and as well as you all know, his role in research work of bariatric surgery, that is the dominant role, and also sharing knowledge. It's great honor to have such a prestigious figure. And I just inform you. So as you know, we have finished interview series of MGBOAGB, then interview series of Roux-en-Y gastric bypass, interview series of safe sleeve gastrectomy, and now we have started interview series of metabolic surgery in low BMI diabetic patient. We have started this series with Professor Alper, and then we will continue this series till December, and hope every Tuesday, such at 10 p.m. Dubai time, we will have such an expert. And today, so it's great honor for myself to interview Professor Kermansaravi, and he will share his personal experience and his team experience about surgical treatment of diabetes or metabolic surgery in low BMI metabolic patients. Sir, so much thanks for your time. Over to you.
Hello, everybody. Thank you, Dr. Abbas, for giving me another opportunity to discuss about different aspects of bariatric and metabolic surgery. I'm at your service.
Sir, so much thanks. And as you know, because we have divided these questions in 3 steps, some pre-op, then post-op, and then we will talk some technical points, and then we will talk about the results and post-op, your technique. So first of all, personally, I know yourself, but for my viewers, your brief introduction and also your journey of this metabolic surgery in low BMI.
I started as assistant professor of surgery of the School of Medicine of Iran University of Medical Science in 2017, and with Professor Pazuki, trained the fellowship in MIS and bariatric surgery, and we introduced for first time the sleeve jejunal bypass, single anastomosis sleeve jejunal bypass, as a novel procedure for metabolic and bariatric surgery. I started the metabolic surgery in low BMI patients in 2017.
Sir, excellent and excellent, as you have mentioned. So your technique is a sleeve plus. So a sleeve plus entro jejunostomy or gastro jejunostomy. Definitely, that is a novel procedure, and we will talk about also technical points. But first, because in this pre-op session, we are interested to know your selection criteria. So how you select your patients, which patient is, and especially you must mention BMI, especially low, the lower limit of BMI. And also, what is your criteria? Are you evaluate pancreas? Are you check any other lab test? So which candidate is a good candidate for such a surgery?
As you know, the patient with BMI lower than 35 and with uncontrolled diabetes are good candidates for metabolic surgery. International Diabetic Organization in 2016 endorsed metabolic surgery for type 2 diabetes mellitus patients in class 1 obesity. And for Asian population, they endorsed it, as you know, for BMI 27.5 to 32.5. And but as you know, BMI is not a good tool for choosing the best treatment for a patient with type 2 diabetes, because the patient, the BMI does not show the adipose tissue distribution, and doesn't consider the race, the age, the ethnicity, and the gender and the body composition. So BMI is not a very good criteria for selection the patients. For every patient, I decide to do metabolic surgery for them. A diabetologist should visit the patient and confirm that the patient is ready to metabolic surgery, as is fit to metabolic surgery. As you know, metabolic surgery may be potent, and but may have some side effects that we'll discuss later. So metabolic surgery in a patient should be evaluated in some aspects. We should test the pancreas reserve, such as C-peptide level. You know, C-peptide more than 2 nanogram per deciliter may have a good response to metabolic surgery, and lower than 2 may poor response to metabolic surgery. And I test the hemoglobin A1C. As you know, hemoglobin A1C is better to be lower than 8.5 to decrease the morbidity and mortality after bariatric surgery, after metabolic surgery. So I check all of the lab data that needs for bariatric surgery, such as albumin, total protein, LFT, and others. Plus C-peptide, hemoglobin A1C, and maybe the insulin level.
Sir, excellent. So as you mentioned, so BMI is not standard to select these patients. Yes, still we must follow that international guidelines. But again, as you have mentioned, maybe a patient with central obesity, but so BMI is low. So how you select your patients? So because we are interested, because you are working in an institute and you are a researcher. So what is your criteria? BMI is not a standard. So how you select? So are you going to do, if a patient is BMI with 23, patient with BMI 25, but central obese, just imagine C-peptide is 2.5, and you can see, yes, the stimulated C-peptide are stimulated insulin. The response is everything good. And yes, you think there is beta cell reservoir is okay, and already you have ruled out LADA or autoimmune impact, and that patient is definite diabetes type 2. So will you go for such a case with BMI 23 to do this surgery?
As you know, Persian patients or Persian people has Indo-European. So I do only metabolic surgery for the patient with BMI 30 or more.
Okay.
And for every patient, I will a consultation with endocrinologist, as I mentioned before. If the main endocrinologist confirm that the patient will a good responder to the metabolic surgery, I will do metabolic surgery for the patient.
Sir, excellent, excellent. And yes, so this is your patient selection criterion, BMI 30 plus. And if C-peptide is 2 plus, then this patient is a good candidate for metabolic surgery. Are you rule out LADA or autoimmune impact in such a case, or no need? When patient is 30 plus, so definite patient is class 1 obesity overall, so there will be a benefit from surgery.
Yes.
So sir, now we will talk about some technical points. First of all, we are interested, if you have any short video of your technique, we are interested to watch your video, then we will ask some questions.
Yes, I should mention that generally I do Roux-en-Y gastric bypass for these patients. And in few patients that need surveillance endoscopy, I may select the sleeve jejunal bypass, but generally do Roux-en-Y gastric bypass as I show in video, because I think the operation should be reversible in these patients because they are more prone to excessive weight loss. So I select the Roux-en-Y gastric bypass, generally Roux-en-Y gastric bypass in these patients.
So in this case, when BMI is 30, what will be your BP limb?
My BP limb may be between 80 centimeter to 1 meter BP limb. And usually the alimentary limb will be 75 centimeter.
And have you any video of your that sleeve plus enterojejunostomy?
Yes, in some situation, I do a sleeve plus procedure, but SASI procedure, not SASI. I think SASI is very.
SASI, this is not, you will, so have you any video to show that SASI or SAJ if you are?
No, I will show my video Roux-en-Y gastric bypass. Can you see?
No, not yet.
Can you see or not?
Yeah, now I think we can see.
I generally create a longer pouch in these patients.
So, okay, we will discuss if you have longer pouch.
Longer pouch about 6 millimeter because
6 centimeter.
6 centimeter. Because I think we don't need the restrictive aspect of bariatric surgery in these patients. It's about a 6 centimeter. And as I mentioned before, I usually create a biliopancreatic limb between 80 to 100 centimeter. Then I do gastrojejunostomy by loop technique, as you know, and a single layer PDS running suture. Then I do measure full of ball length, and I should confirm that the patient has at least 3 meters of common limb and 4 meters of total alimentary limb length. I mean, the alimentary limb length plus common limb length should be more than 4 meters. And I should be sure that patient have a low risk for nutritional deficiency after the surgery. It's a Peterson defect that we close in all patients, and then a leak test during the surgery.
So excellent, sir. Excellent. I think so. This is a standard Roux-en-Y gastric bypass. Maybe we have no question about Roux-en-Y technique. But my question also, Professor Laurent Layani also is live, and he's also his question about selection of Roux-en-Y for low BMI, because if a patient is BMI is 30, and we will do this Roux-en-Y gastric bypass, and BP limb is just imagine 80 plus, and as well as Roux limb is So about we bypass 200. Yes, I know that carbs absorption is in ruling, but in overall in diabetic patients, so we prefer they don't use carbs in their food. So the definite carbs is less in diabetic patient. There will be high protein diet, especially also after surgery. So when high protein diet, and as we have about 175 bypass this protein, and protein will start to absorption when bile and this biliopancreatic juice will join in common channel. So what's my question? So in your series, how many cases you did these cases, especially low BMI and Roux-en-Y, and what was your result? Have you any data?
I have done 50 patients, only 50 patients. Okay. And in my series, I had no malnutrition. I had 2 excessive weight loss. I mean the patients with BMI lower than 18, but 2 of them were managed with nutritional conservative management, and I didn't any reversal for these patients, and I think both SAS bypass and Roux-en-Y gastric bypass with as I mentioned before, 80 to 100 centimeter is safe in these patients.
Okay, sir. Yeah. Also, my question, and also this question is from Laurent as well. So, if you will go for MGB in such a case, so with little wider pouch, and shorter BP limb. So maybe it's also easy to reverse and also easy to do, and maybe more effective. So, can you think in future?
Yes. We know that the more potent procedure have more effect in diabetes resolution. So biliopancreatic diversion is very potent, more potent than OAGB, and OAGB is more potent than Roux-en-Y gastric bypass. But as you know, the published papers about metabolic surgery reported medium-term and short-term result. My concern is about long-term result. We don't know, for example, after 10 years, what will happen to these patients. So I generally do Roux-en-Y gastric bypass, a less potent procedure for these patients. But as you know, my Professor Pazuki, generally do OAGB for his patients.
Yeah. So another question regarding this your procedure sausage. So can you explain, and how much your experience this procedure, especially sleeve plus that gastrojejunostomy, and what is your feeling about this? Is it okay? We can go ahead with this surgery, and because you definitely you did, or your colleagues did more cases in low BMI. Such we are interested to hear more about sleeve plus.
I did a few cases with such procedure in low BMI patients. As I mentioned before, Roux-en-Y gastric bypass is my first choice in these patients. But generally about SAS bypass that will publish together the result of SAS bypass in Iran, nearly God willing. We have good result about obesity related medical problems and weight loss outcomes. I think it's a good procedure, but should be an alternative procedure for more standard procedures such as Roux-en-Y gastric bypass, OAGB, and sleeve gastrectomy. I generally do such bypass only in patients that has a great indication for surveillance endoscopy. For example, a positive family history for gastric cancer, or focal intestinal metaplasia, or some lesions in antrum that the patient needs surveillance upper GI endoscopy. It's not a routine procedure for me. Hence, Professor Pazuki and me first introduced the SAS bypass, but we don't use it as first procedure for the patients, for only patient that has indications for surveillance endoscopy.
So you have mentioned, so these patients maybe lose more weight, but when you will do this surgery, just imagine your BP limb is 150, 180 from Tritt's ligament. So you have sufficient common channel, a BMI 30, a wide sleeve with enterojejunostomy, and the size of this enterojejunostomy is about 3 centimeter. So I don't think a patient will lose such a weight, and I don't know. This is my personal experience because routinely I am doing this surgery, and really I'm happy. My patients are happy. Since 2016, I have started this, and now hundreds of cases I did with this technique. Till I also do stapleless SASI. What mean? So I placate the stomach. Oh no, without any stapler, and thus I do enterojejunostomy. That is about 150, 180. So a patient BMI is 35. So maybe this BP limb will go to 200 if BMI is 40. But happy really now for 5 years. Following just one case, I revise. So maybe in that patient, the whole length was shorter because I didn't measure whole length. And then just I cut that loop, and then she gained weight. She is now happy and there is no issue. So because I was curious about to know more about this technique. If you have any experience about especially this SAJ technique, sausage.
Such technique, we only use a 1.5 meter, 1.5 meter in all patients. We don't measure whole ball length because it's a bipartition procedure, and it's a proximal bypass, not distal bypass. So we don't measure whole ball length, and in all patients, 1.5 meter biliopancreatic limb with a 3 centimeter sleeve jejunal anastomosis from 3 centimeter of pylorus, proximal to pylorus, upward position, upward. And we don't have any excessive weight loss. We didn't perform any reversal or any conversion. We'll publish our results soon.
So excellent, sir. So these diabetic patients are low BMI. So have you any data which percentage of your patients achieve complete remission in your cases, in your study, or in your?
As I mentioned before, my cases, my patients have medium follow-up results, not long-term results. In medium term, about 70% of my patients, generally with different clinical criteria. As you know, we have many scoring system to predict the response of patients to metabolic surgery, such as ABCD system, DIRM system, IMS system. But generally, in our series, more than 70% of patients have complete remission after metabolic surgery, and less than 10% had remission, had recurrence after the surgery. As you know, obesity is a chronic disease, diabetes is a chronic disease, so recurrence is not rare, is not uncommon, but is rare. In my series, less than 10% of patients had recurrence. Recurrence, I mean, not complete remission.
They have improvement, but maybe
Improvement.
improvement, but this was not complete remission. So my question, so now if as a surgeon, so what is your suggestion, which patient, when we are selecting the patient? Yes, you have highlighted your selection criteria, metabolic surgery in low BMI, but again, when you see, oh, this patient is now 65 years old, about 32 years, she's suffering with the diabetes. She also already she had nephropathy, maybe some stages of retinopathy, and already she had 2 stents, maybe one the diabetic foot, but C-peptide is 2.2. So BMI is also, yes, 32, 33, and she's fit for surgery from cardiology, cardiology, no issue. So is this patient is good for surgery? You will go for such a case?
Retinopathy and nephropathy may be worse after diabetic surgery, maybe worse. We have many published data about these patients. After complete remission, nephropathy may continue. So this patient may not a good candidate for metabolic surgery. As you mentioned before, the patient with diabetes duration more than 5 years, or especially more than 10 years, not good candidate for metabolic surgery. They have poor response, and the chance of recurrence is high.
So then Dr. Zandi also, so my thanks. Dr. Zandi is appreciating to invite you. Dr. Zandi is live with us in this interview. So Doctor, yes, you have highlighted, so this is very important to know about this. Already you have mentioned HbA1c is very important, but so you have mentioned, so 8 point plus, 8.4 plus, so when there is less chance, I don't know, as I understand. And also now you have highlighting, if patient is suffering already with some microvascular complication or side effects of diabetes, that is so when, and also long time suffering with diabetes, these are negative points, and so prediction. So then we must talk with the patient. Patient must be oriented. So unfortunately, just patient think, when I will do surgery, everything is okay, everything is fine. But my question regarding this worseness of these microvascular complication, why it happen when we do surgery? Definite, then atherosclerosis will be less after some time, and those this blood supply will be better. So our expectation and personal, my experience that I see in my patients, nephropathy at least, so it improved better. I don't know, what is your personal experience? Because you know better than me, especially this data. And
there are many published papers that confirm especially retinopathy. Retinopathy is established procedure after starting. So retinopathy may worse, not usually worse, may worse after even remission of diabetes mellitus. So we should announce the patient that after the surgery, you may have the recurrence of diabetes. You may have progression of retinopathy. The patient should be announced. We should say the patient that higher age, lower BMI, lower C-peptide, higher hemoglobin A1C, and higher duration of diabetes, and insulin usage are negative factors for prediction of diabetes resolution, remission. We should say our patients as a physician, as a surgeon.
so now, so this is another question. So in your selection criteria, when you are select your patient, especially this diabetic patient with low BMI, is it routine to check with ophthalmologist, or you must check to rule out any type of nephropathy? Is your routine practice?
No, I don't do it routinely.
So when you select the patient, this patient, if patient is suffering more than 15 years now, 60 years old, have you any criteria to send the patient? Okay, yes, other than this nutritionist or other cardiologist, you must also go to ophthalmologist, or must go to do these tests to rule out any type of like microalbuminuria or something like this. Maybe before this patient has no checkup, he has no idea about nephropathy, but so yes, you select one from these 10 patients. This patient must go do this.
In the patients that the patient have albuminuria, microalbuminuria prior to surgery, I usually send them to nephrologist.
Okay. No, my question. So which patient you, have you any criteria? So in your practice, yes, this patient I must rule out nephropathy. Yes, not routine, but selected patient. What is your selection criteria to send the patient? Patient has no complaint. Before this has no test. He has no complaint of retinopathy, but okay, you highlight this patient. Maybe this patient is at initial stage of nephropathy or retinopathy. He must go, not all the patients, but when you see, yes, patient is 60 years old, now more than 20 years suffering with diabetes, and maybe family history positive, I don't know. Have you any criteria to?
No, I have no criteria for retinopathy, was that mentioned before, only for patients that in their UA have microalbuminuria, I send them for nephrologist consultation.
Nephrologist. Yes, overall, this is, it's excellent. Sir, regarding this, so overall, if we see response of these patients, these diabetic patients, so when you will discharge the patient, are you continue there like this patient was taking, because they think about this when we will do the surgery, so then we will not need any type of medicine. But so this is the definite so expectation of patient. So patient is taking about 50-60 units insulin before surgery. Now second day or first day after surgery, you will discharge the patient. So what you will ask the patient? You must continue this insulin, or you have a special protocol for these cases? How you deal these patients?
We have a guideline that the patients should be admitted in hospital until their FPS lower than 140. As the same as bariatric surgery, metabolic surgery needs a multidisciplinary team approach. So generally my patients have to be visited by an endocrinologist before and after surgery. Endocrinologist adjust the dose of insulin or the anti-diabetic oral agents for every patient before discharging from hospital.
It's good. The patient will stay in hospital till FPS will be less than 140.
Yes.
So maybe then stay will be longer. So maybe patient will stay 7 days, 10 days. So sometime this, because this is my experience. So you can't believe. So this FBS will not come less than 140, 200, 200 plus after surgery.
Generally, the patients will have less than 140 at the day after surgery or 2 days after surgery. I have good experience about their improvement of diabetes, maybe to my selection criteria, because I don't operate every patient.
Yeah, maybe. So excellent. And what is your concern? So when you are doing a patient low BMI with diabetes, So after surgery, what is your main concern in these cases? Some, because personally, I have faced one case that was diabetic type 2. I confirmed, I checked everything, but patient, she was 50 plus her age, but after surgery, ketoacidosis. I faced one case.
Ketoacidosis is very important and more common than ketoacidosis is postprandial hypoglycemia. It's about 10% incidence after metabolic surgery in diabetic patients, especially after gastric bypass. Postprandial hypoglycemia may be very serious, and should be considered in every patient after metabolic surgery. It's the most concern of me for these patients. Another concern, excessive weight loss and nutritional deficiencies such as hypoalbuminemia is other concerns in these patients.
So how can we prevent this? Because this is the main concern really, that this postprandial hypoglycemia. So how can we prevent such a situation? And we must be ready for such so it will be disaster if we will not manage.
Yes. The first step is dietitian consultation. The patients should use low carbohydrate and high protein meal, and the patients should guide to use the meals with suitable texture and size, and the patients may need to use acarbose, GLP-1 agonist, somatostatins, SGL2 inhibitors, and maybe due to surgical complications. As you know, a narrowing of jejunostomy or any kinking of jejunostomy or gastrojejunostomy due to adhesions may lead to postprandial hypoglycemia. The purpose of this condition is overgrowth of bacteria, and bacteria use the glucose in a small bowl, or maybe the metabolism of bile acid that may be altered in kinking or narrowing of jejunal anastomosis. I read a paper about this problem that in high volume center, they corrected the stenosis of jejunal anastomosis of most of patients, has had remission of postprandial hypoglycemia.
So this is your main concern, especially a patient with diabetes. And when we will go for metabolic surgery, the main concern is hypoglycemia. So
Yes.
not definite when, because patient in such a situation, and sometimes they also continue to use their medication. They are not completely aware about this, and then it will be definite disaster. So if a patient, so have you any suggestion to your patients, if some person like these symptoms, what he do at spot? He must take little any juice, any sweetener, always he must with his hand. So what's your suggestion to your patients if patient is suffering with such a situation, what he must do?
Prevention is the most important to treatment. As I said, the patient should encourage to use low carbohydrate and high protein food.
Okay. When he will use this, so definite, then there will be less chance. So maybe you are talking about dumping. So sometimes, so when he will use more carbs, so there will be dumping. We have also early dumping, late dumping. Are you talking about this?
Yes, dumping is more common, and less dangerous than hypoglycemia. Dumping is preventable, simple, and very simple to treat. The patients should avoid to drink liquids from 30 minutes before the meal to 30 minutes after the meal, and should avoid the sweet and high fat foods. And I think the preventive methods can prevent the dumping syndrome. It's a good or less harmful uh, situation, but postprandial hypoglycemia is a disaster.
I understand, doctor. So another thing that is especially more concern in diabetic patient, because when diabetes type 2, we have insulin. So there is a resistance to insulin that is the main cause of diabetes type 2. So what will happen? So patient has sufficient insulin. There is no issue for insulin. And when we proceed a procedure, metabolic surgery in these specific patients, and within 2 or 3 days, due to rise of GLP-1, and again, impact of GLP-1 on beta cell, that also stimulate more secretion of insulin. So definitely, maybe patient will suffer with the hypoglycemia. And also that, as you have mentioned, so we must aware our patient after this surgery. So be careful, because hypoglycemia is more dangerous. Are you agree?
Yeah, I agree. Completely agree with you.
So this is due to this. So we must aware our patients. If patient is using any type of medication, be careful. So if the dose and everything, sometimes they also inject insulin. Okay, no issue. No, there is an issue, because this is a type 2 diabetic patient. Already patient has sufficient insulin. Just imagine C-peptide is 2.5 plus. So sufficient reservoir of pancreas we have already, and there is no autoimmune impact in this case, pure diabetic type 2. So definite, then we will aware the patient about such a situation. Sir, have you revised any diabetic patient after metabolic surgery, and why you have revised?
In my series, no. I have no revision or conversion in my series.
In your experience, there was no revised surgery. So regarding our patients, especially these diabetic patient, because nowadays in social media also we can see a lot of awareness program about metabolic surgery. So one thing that's the most important, so the differentiation between type 1 and type 1, type 2 and type 1.5. Type 1.5, that is a LADA, or that is a patients. So with low BMI, thin patient, but old patient. So patient, this is not type 1, but that is type 1.5, that is LADA. Definitely, as you have mentioned earlier, because you will not do surgery in thin patients and less than BMI 30, so definitely you will not deal such cases for metabolic surgery.
In LADA, we have few published articles that show the efficacy of metabolic surgery in LADA. But in metabolic surgery in LADA needs more investigation to confirm. As you know, it's only metabolic surgery is only endorsed for type 2 diabetes mellitus. We can use it in type 1 diabetes mellitus in obese patients, in patients with obesity, because after surgery, the patient need for insulin will decrease. It will happen as the same for LADA patients, but as I mentioned, it needs more investigation to be endorsed for these patients.
Have you any experience of type 1 in obese patient?
I have only 2 patients. Yes, 2 patients.
2 patients, and the patients are happy.
Yes, because the patients are no uh, mm, lower need, decreasing needing for insulin. But as you know, the patients has no insulin production, so will need insulin lifeline with
Yeah,
lower dose.
in lower dose. Yeah, personal also I did one surgery for type 1, and alhamdulillah now more than 4 5 years, and she's happy. I did mini gastric bypass in that patient. She was morbid obese, but type 1. And also you can't believe doctor showed nephropathy and advanced stage, and now also that results good. And she's using insulin still, but much less dose, and enjoying her life. So because in metabolic surgery, definitely you know better than me. So I think this is new child baby still in bariatric surgery field in low BMI, and still we need more and more and more research work and more publication to mature this surgery. Because if we see, so real pandemic at the globe is diabetes. There is, I think, no one. So in their family, they are suffering with diabetes and lot of complication due to diabetes, and this is the time. So we must so standardize our techniques. We must discuss with each other, and this is the one of the way that I have started this interview series of metabolic surgery, especially in low BMI. Yes, we do. We routinely do morbid obesity cases and like different types of surgeries. Patient may be diabetic, maybe not diabetic, but in low BMI, when we will go, so what is our criteria, how we select these patients, which surgery is best for the patient. So earlier you have mentioned BMI is not a standard for us. So what is our standard? We must discuss about this. So is this ratio of waist hip ratio is okay? So I have no idea. So this is personal, like you must standardize this, in my opinion, and you must be go ahead. So, and please standardize this selection criteria in this low BMI patients. Are you agree?
I agree. We'll do together, God willing.
Yeah, because this is the time. This is the time. I completely agree with you. So BMI is not standard in these patients. Just imagine, especially in South Asia, when, yes, I know Persian people is like, so European, yes, their anatomy, and so we cannot ask. So there is low BMI in Persian people, or again in Dubai that I am sitting here in Middle East. But when we go to South Asian people, so especially vegetarians, so they are central obese. Okay, maybe BMI is 23, but central obese. So I must help these people. So then what is our criteria? So definitely BMI is not our criteria. We must think about this. So especially patient selection. When patient selection will be standardized, then we will talk about technique. So which technique is better? So because if we will go for hypoabsorptive techniques, then there will be more chance of micronutrient deficiencies, more chance of weight loss. So then we can standardize, yes, this technique is better for this patient in this such a situation.
I agree with you.
Sir, really so much thanks, because I know you're so much busy, and personally I have learned a lot because in this session, so I think I am first student, because I learn always a person like you. So for our youngsters who are just now going to start metabolic surgery, so what is your message for such a youngsters?
I think metabolic surgery is more important than bariatric surgery. So the surgeons, if want to start metabolic surgery, should be experienced in bariatric surgery, because the patient selection is maybe more important in low BMI patients, and the complications more be maybe more in these patients. So after getting the complete experience, can start to do metabolic surgery.
Sir, so much thanks, and really, so always you are supportive, always you are encouraging. Anytime, just I send the message and you respond me, and definite in future also we need your support and guidance. in the field of research. That's the most important, because when we will share our experience and data, so this will be also one of the type of sharing knowledge. Sir, so much thanks, and also thanks for my viewers. So these sessions are due to your support, and with your support we will continue this session, this interview series of low BMI metabolic surgery in low BMI diabetic patient till December. And in December or January 2023, we will have a sum up session. And then next we will continue with redo surgeries. Sir, so much thanks. And again, next week, Tuesday, 10 p.m. Dubai time, we will be with another so legend, definite, and also expert of metabolic surgery in low BMI. Sir, so much thanks, and have a nice time.
Thank you. Good night.